Welcome everyone to the Gippsland Regional Integrated Cancer Services Annual Forum. I'm Mark Johnson, CEO of Gippsland Southern Health Service and Chair of the GRICS Governance Group. To begin the evening, I'd like to invite Gail Menzies, Curie Liaison Officer at La Trobe Regional Hospital, to provide the welcome to country. Thanks, Gail.
Thank you. Womaninji and welcome. My name is Gail Menzies and I'm a proud Gunai-Kurnai woman and would like to welcome you all here today on the lands of the Gunai-Kurnai Nations and acknowledge the Brakalong land that I sit on today. I wish to pay my respects to the elders both past and present and to our future leaders and identify with their strength and resilience. As a transient nation, I would like to acknowledge and show respects to the Aboriginal and Torres Strait Islander people who now reside on Gunai-Kurnai land, and also pay respects to all Aboriginal people present here this evening. As a proud Aboriginal woman, I'm respectful and proud to walk on the lands of my ancestors and elders, respecting their spiritual connection to the lands and the waters, respecting my people. It is who has come before me with their self-determination, guidance and resilience that has made me who I am today. Speaking as an Aboriginal woman, equality and rights to equal justice have been an ongoing battle. High rates of family violence, overrepresentation of Aboriginal women in our prison systems, which is at 29%, between 1905 and 1970 saw the forced removal of children, the stolen generation, targeting children of mixed descent to eventually assimilate and wipe out the Aboriginal race. In 1962, the Menzies Liberal and Country Party government finally gave the right to all Aboriginal people to vote. Prior to that, Aboriginal people were classed as flora and fauna. The injustices done to my people were horrendous. History needs to be taught and acknowledged. Conversations need to be had. We still have a long way to go to heal and move forward. As we look to the future, we honour and remember those trailblazers before us who paved the rights and have the rights we have today. We recently celebrated NAIDOC 2020, always was, always will be, recognising that our First Nations people have occupied and cared for this continent for over 65,000 years. We all have a story to tell, and it starts with knowing who you are and where you come from. We can all lift each other up and we all have the power to make a difference. As a proud Aboriginal woman, I respect the land that my ancestors and elders walked on, the waters that drank from, the flora that we ate from, respecting my people and being proud of where I've come from, knowing that I am loved, I am heard and I am strong. So traditionally, a welcome to country is when a visitor from a different clan would wait outside the boundary until permission was granted to enter. This may have been signalled by a lit fire to ask for permission. Visitors would risk punishment for crossing boundary clan lines without permission. So today, as a proud Gunai-Kurnai woman, I would like to welcome you all here today on the lands that I sit on, Brakalong land, and offer you all a safe passage on the lands of the Gunai-Kurnai Nations. And I would like to wish you all a successful optimum care pathway forum for Aboriginal and Torres Strait Islander people with cancer. Yarrabi. Thank you.
Thank you, Gail. Before we proceed with the presentations, I'd like to cover off a couple of housekeeping tips. We'll have some time for questions at the completion of Dr. Ristevski and Professor Garvey's presentations. So for any questions, please use the toolbar indicated on the slide. Secondly, there'll be an evaluation survey for the forum emailed to you after tonight's event. We would greatly appreciate it if you could complete the survey and return it to us. For those of you who are not familiar with the Integrated Cancer Services, GRICS is one of the 9 ICs funded by the Department of Health and Human Services. GRICS works in partnership with Gippsland Health Services, the local primary health network, and the Department of Health and Human Services, as well as other ICs, with the aim of improving patient experiences and outcomes by connecting cancer care and driving best practice. Tonight's forum has a focus on the optimal care pathway for Aboriginal and Torres Strait Islander people with cancer, and will include presentations from Professor Gail Garvey and Dr. Ristevski. GRICS will also provide an update on work undertaken, as well as an outline on future projects. Before we go any further, I'd like to make mention of the interesting past 12 months we've had. This has included the cybersecurity incident, which affected the Gippsland Health Alliance network for a long period of time, the bushfires in East Gippsland, and the current COVID-19 pandemic. These have caused GRICS to put a number of projects on hold, but has also given us an opportunity to plan new initiatives, which you'll hear about throughout the evening. To kick off our presentations tonight, we'll be hearing from 3 of the GRICS staff members who will provide a quick snapshot of the projects undertaken throughout the year. Emily Capaldo, Michelle Price and Hayley Hall are all Cancer Service Improvement Coordinators with GRICS. So let's start with Emily.
Hi everyone, I'll be speaking about the head and neck OCP and supportive care. Firstly, the head and neck OCP. It was identified through the implementation of the head and neck OCP that there is no evidence of complex head and neck cancer patients being referred from Metro Health Services to Gippsland Hospital or community-based allied health services for follow-up care. It was also identified that there are currently limited allied health clinicians locally with specialist knowledge to care for complex head and neck cancer patients. This project aims to provide a comprehensive education package for Gippsland Hospital and community-based allied health clinicians to enable best practice follow-up care. The upskilling of clinicians will lead to the development of clinical champions. In turn, we hope this leads to the establishment of referral pathways for Metro patients back to Gippsland. In partnership with Peter Mac, the education package consists of 4 components: online learning modules, community of practice mentoring program, allied health head and neck cancer symposium, and shadowing placement at Peter Mac. Due to the cyber attack in 2019 and COVID-19, the delivery of the package has been delayed. We have, however, managed to proceed with the community of practice mentoring program. 6 dietitians and 9 speech pathologists are enrolled in the program from across 5 of our major health services. This symposium is tentatively booked for mid-2021, and so far we have 21 registered participants. The online modules will hopefully be accessible early next year, and placements will begin when restrictions permit. Now on to supportive care. So the supportive care refresh and We Can has involved the development of a supportive care patient information brochure for our region, the delivery of supportive care education, which included the introduction to We Can and the supportive care brochure, to 28 nurses at 5 chemotherapy day unit sites in our region. At most chemotherapy sites now, this information is now provided to patients during their pre-treatment education sessions. The refresh also included a new EverQ supportive care learning module, which was introduced to the chemotherapy day staff also. We Can and the supportive care brochures were also introduced to Gippsland Radiation Oncology, and that they now provide these to the patients at their planning sessions. Pre-COVID, we had made plans to meet with all of the health services in our region to discuss the introduction of supportive care screening, We Can, the supportive care brochure, and also the optimal care pathways, what to expect guides in the inpatient units. But because of the situation with COVID, this is currently on hold. That's all from me. I'll now hand over to Hayley. Thanks.
Thanks, Emily. Here at GRICS, we've continued our focus on the lung and colorectal optimal care pathways with a focus on MDMs. Auditing of the lung and colorectal MDM treatment plans highlighted to us that ECOG performance status documentation was below the CSBI target of 100% and staging documentation could be improved. After consultation with experts in the lung and colorectal cancer field within Gippsland, ECOG and staging classification guides were developed for use within the lung and colorectal MDM. This is an example of the colorectal guide. These guides serve as a prompt for MDM members to enhance ECOG and staging documentation in treatment plans. Evaluation of these guides show they have been successful in increasing ECOG and staging documentation in the MDM treatment plans. GRICS is looking at developing guides for additional tumour streams due to this success. Here at GRICS, we've also continued with our community ambassador program. This is where trained volunteer speakers with a cancer experience present to community groups to increase health literacy on cancer. 3 presentations to 61 attendees have been accomplished this year with very positive feedback as shown. We look forward to continuing with this program and exploring online options due to COVID. I'll now hand over to Michelle. Thank you.
Thank you, Hayley. Continuing with the consumer theme, I'd just like to talk very briefly about the VIX Interix Consumer Forum, which was held in August in Melbourne last year. The forum was definitely a winner, and the GRICS consumers and program staff who attended all agreed that they'd garnered a lot of information and insight into consumer work across the state. The broad aims of our forum were for consumer attendees to network, learn what's happening in other areas, share ideas and brainstorm future initiatives that we might work on together. In total, 48 people attended the forum with representation from 7 of the 9 ICs. We were very well represented from Gippsland with 4 of our consumers attending, and they definitely contributed to the success of the day. Following the event and heeding advice from consumers present at the ICS forum, a statewide consumer engagement peer group has been developed. There are representatives now from all of the integrated cancer services, and the aim of this group is to promote a cohesive, collaborative approach to working with people with lived experience of cancer. I'm very passionate about psycho-oncology, and we've developed an initiative to try and move this service forward in Gippsland. People vary in their emotional responses to the circumstances surrounding a diagnosis and treatment of cancer, and people's distress can change over time. There is some evidence that suggests that psychological distress, especially leading to depression, can lead to a poorer prognosis for cancer disease. Following the 2019 GRICS Annual Forum, the theme of which was psycho-oncology, a discussion paper proposing further research into psycho-oncology services locally was approved by the GRICS Governance Group. Since that time, GRICS project staff have met with Gippsland Mental Health Services and other providers to seek an understanding of the level of demand, current service capability, and the degree of any subsequent gap in psycho-oncology services for patients in the region. Additionally, we've developed a statewide regional working group that's been formed to explore the possibility of implementing an initiative across all regional jurisdictions and possibly providing education to community psychologists. So watch this space.
Thank you, Emily, Michelle and Hayley. Next, it's my great pleasure to introduce our keynote speaker for this evening, Professor Gail Garvey. Professor Garvey is a Kamilaroi woman from New South Wales and Senior Principal Research Fellow, Wellbeing and Preventable Chronic Diseases Division at Menzies School of Health Research. She has worked for over 30 years in Aboriginal health and has an impressive record in building Indigenous research capacity and a strong track record of research translation into policy and practice. Professor Garvey plays an important leadership role in Indigenous cancer research nationally and internationally. She has led successful national research programs and is currently leading an NHMRC Centre of Research Excellence in targeted approaches to improve cancer services for Aboriginal and Torres Strait Islander Australians. Her research into the psychosocial aspects of cancer care for Indigenous patients is a critical component to improving their cancer care outcomes. Professor Garvey has established an international collaborative research program of work in cancer and Indigenous peoples with the International Agency for Research on Cancer, an intergovernmental agency forming part of the World Health Organization of the United Nations. Professor Garvey will now provide an introduction to the optimal care pathway for Aboriginal and Torres Strait Islander people with cancer, as well as the National Aboriginal and Torres Strait Islander Cancer Framework. Welcome, Gail.
Thank you very much, Mark, for that introduction. And I'd like to thank the Gippsland Health Services and GRICS for the opportunity to attend the forum today and share a little bit of the work that I've been doing in cancer with Aboriginal and Torres Strait Islander people. Before I do that, I'd like to acknowledge the Brackalung people and Gail's welcome and acknowledge and pay respects to traditional owners past, present and emerging. I'd also like to acknowledge the traditional owners of the lands in which I am today and acknowledge the Turrbal and Jagera people. And I'd also like to acknowledge Aboriginal and Torres Strait Islander people who are present today. This first presentation is a very short snapshot. It gives an introduction to the Aboriginal and Torres Strait Islander Cancer Framework and the optimal cancer care pathways for Aboriginal and Torres Strait Islander people. I'm just going to share my screen and then I'm going to turn off the video so I don't look at myself during the presentation. Okay, so as I mentioned, this is a brief introduction to the Aboriginal and Torres Strait Islander Cancer Framework and the optimal cancer care pathway for Aboriginal and Torres Strait Islander people. And it's really important that we get some context of this before Ellie does her presentation around, you know, health professionals' understanding in the Gippsland area about the optimal cancer care pathways. That's the acknowledgement. And so firstly, you may have seen this document. It was developed some time ago, back in 2015. I was very privileged to be the lead consultant on this work with Cancer Australia. And it's the first national cancer policy for Aboriginal and Torres Strait Islander people. Provides high-level guidance and direction to address disparities and improve cancer outcomes. And recently, Cancer Australia has looked at this framework, and whilst it was developed back in 2015, a lot of the priority areas and the enablers that are in this document are still relevant today. So there are 7 priority areas in this framework, and you can see them outlined on this slide here. And each of these priority areas in this document have a series of enablers that really help health services in the direction and how they might address each of these priority areas within their own local area health service. So today we won't have time to go into detail into each of these priority areas. We're going to look at a few in a moment, but I suggest that you have a look at one of the at this document after the presentation today. So priority framework, priority 1 in the framework is really around understanding that there's a widespread lack of knowledge about cancer, particularly amongst Aboriginal and Torres Strait Islander people, and its causes, its symptoms and its treatment. And so this is likely to impact significantly on Aboriginal and Torres Strait Islander cancer outcomes. And so you can see here that to address this priority, there are a number of enablers. And these are suggestions really for health services and for other organisations in trying to address this priority area. So it's around ensuring that information is available and accessible for Aboriginal and Torres Strait Islander people across the cancer continuum, from prevention to early detection right through to palliative and end-of-life care. And ensuring that that information is appropriate and in languages that are suitable to the needs of Aboriginal and Torres Strait Islander people. And Michelle was just talking about, you know, a consumer forum and the lived experience. And also one of the enablers in this priority area is promoting cancer literacy through broader forums. And that could be through consumer forums like Michelle just mentioned. So priority 4, this is another one, and I thought it was important to show the group this one because it's really around ensuring early diagnosis of symptomatic cancers. And this is a particularly important priority area because we know Aboriginal Australians are more likely to be diagnosed with cancers that have progressed to a more advanced stage compared to non-Indigenous Australians. And so that obviously contributes to high mortality rates. So to address this priority, these are some suggested enablers in the cancer framework. Improved knowledge about cancer symptoms and the benefits of early detection. Increase access to diagnostic services, particularly in rural and remote areas. And, you know, I think it was Hayley or Emily talked about, you know, access to services and working with Peter McCullum so that people in the Gippsland area can access the same level of services that if you're more urban. And so that's the same sorts of things that are mentioned as enablers for Aboriginal and Torres Strait Islander people in this framework. So just quickly having a look now at the optimal care pathway for Aboriginal and Torres Strait Islander people. And so this OCP, we know that there's tumour-specific OCPs and that they were developed to provide an understanding of the whole pathway for the patient and to promote consistent quality cancer care. And so given the distinct epidemiology of cancer amongst Aboriginal and Torres Strait Islander people, and particularly our connection and our culture, and our different ways of making decisions and our history of engaging with health services and institutions, there was a need to develop a specific OCP for Aboriginal and Torres Strait Islander people. And so you can see here on this slide here, it actually gives you in the centre here the Aboriginal and Torres Strait Islander person. And as I said, this is supposed to complement the tumour-specific OCPs, and it acts as a tool for health services and health professionals to improve the quality and safety of care for Aboriginal and Torres Strait Islander people. So you can see on these inner circles, they represent the 7 steps of the cancer continuum, with the outer circle detailing the evidence-based principles that need to be considered when providing optimal care for Aboriginal and Torres Strait Islander people. And so just for those people who may not be able to read it, on the outside, it's patient-centred care, safe and quality care, multidisciplinary care, supportive care, care coordination, communication, research and clinical trials. And you might think, well, that's what we do for all patients. That's right. That's what we should be doing for all patients. But we have to, in looking at those principles, also consider Aboriginal and Torres Strait Islander people and the barriers to receiving supportive care, care coordination or patient-centred care. So implementation of the OCPs is really a long-term commitment, and it requires a whole of system approach. And there is an implementation guide. So if you're not aware of it, there's a link to it at the end of the second presentation that I'm giving. And this is a bit of an overview of what's in this implementation. Information about how to use the guide, introduction, how to get started, what could be some overarching implementation activities, what are some pathways, specific activities, some additional resources and tools. And these are all detailed in the OCP, in the implementation component of it. So in getting started, here's an example of what happened in Canberra, in the Canberra region, in the ACT. They actually looked at mapping the regional cancer centre against the implementation priorities, and this enabled them to identify what they were doing well, but also where the gaps were and what they needed to do to improve those gaps. And Ellie is going to cover more of that in her presentation specific to the Gippsland region. So the OCPs and some of these suggestions, that it's not rocket science, it's not hard to do, it's just making sure that there is someone that's enabling to follow up with these suggestions. So looking at the overarching implementation activities, you can see from this slide here, culturally competent, having a culturally competent workforce. Well, what does that mean in the context of providing cancer care for Aboriginal and Torres Strait Islander people? And here's some, you can see tick boxes to guide you in what that might involve or how you might provide culturally competent care in your health service. These are just guides, obviously localised strategies with engagement with Aboriginal and Torres Strait Islander people is critically important in defining what each of these steps might be. So priority 2 here is around integrated planning and delivery of cancer care. Again, there's a checklist of the sorts of things. So do you have an agreed protocol for how you identify your Aboriginal and Torres Strait Islander patients? So just thinking about that, how do you do that in the Gippsland area? How do you do that in your integrated cancer care system? And then how do you support those patients and how do you monitor them up and down the cancer care journey that they take? The third one here is around culturally appropriate care coordination. Again, it's around effective and culturally appropriate coordination, but also support for Aboriginal and Torres Strait Islander people. And there again, there's some examples here. Some of them relate to, you know, the PATS scheme. Some of them relate to supportive care and how you're providing supportive care and using appropriate tools to assess unmet support needs. And I'll be talking about that in the second presentation later today. So just finally, for this part of the presentation, these are 2 really important documents and resources for you to use as a guide to address the disparities in cancer outcomes for Aboriginal and Torres Strait Islander peoples, their families, but also the broader communities. And I encourage you to have a deeper look into those documents. Thank you.
Thank you, Professor Garvey. Now, before Gail continues with the second part of her presentation, I'd like to introduce Dr. Ellie Ristevski, who will update us with the findings from a recent survey that she led titled Clinician Readiness to Implement Optimal Care Pathway for Aboriginal and Torres Strait Islander People with Cancer. Dr. Ristevski is a senior lecturer at Monash University School of Rural Health, located in Warragul, Gippsland. She is the research co-theme lead for chronic disease, supportive care and ageing at Monash Rural Health. Ellie has a Bachelor of Health Sciences with honours and a PhD from La Trobe University. She has worked in the tertiary sector for almost 20 years, undertaking research and education with undergraduate and postgraduate students in medicine, nursing and health sciences. Ellie is a social scientist with expertise in cancer supportive care and survivorship, palliative care, patient experience of care, evidence-based practice, and implementation of innovative models in practice. Ellie's passion is in improving the experience and access to services for people in rural areas and people in communities who experience significant disparities in health outcomes. Thanks, Ellie. Over to you.
Thanks, Mark, for that introduction. I will just share my screen to get that organised. Sharing screen. Okay, can you see that first slide? Thanks for the introduction, Mark, and thank you to GRICS for the invitation to present at the forum today. Before I begin my presentation, I would also like to acknowledge the traditional owners of the land in which I work on today, the people of the Gunai Nation, and pay my respects to elders past and present. I'd also like to acknowledge the artwork in my presentation that I've used today. It's by Helen Treadgold. So Helen's a local Aboriginal artist in the Latrobe Valley. And she painted this picture for us called The Cancer Journey. And I'd like to draw your attention to particularly the people around the outside of the painting. So in Helen's story about this painting, she talks about the supports for people with cancer, so family and other supports. So to begin my presentation, I want to actually take a step back and tell you a little bit about why we were interested in looking at this piece of work around optimal care pathways. So a few years ago, we received funding from the Department of Health and Human Services to set up and look at cancer survivorship models of care. And in particular, we were interested in culturally appropriate models of care. So to do this, we wanted to talk to Aboriginal people in the Gippsland region and talk to them about their cancer treatment and recovery experiences. So we conducted some yarning with people, and we found out for people the key things that were really important to their cancer treatment and recovery was family and culture. But people said sometimes that family and culture weren't really included and sometimes perhaps not respected by practitioners and health services. And this is the article that we published around this if you wanted to get more information around that. So at the same time, the optimal care pathway was also just being released by Cancer Australia. And at that time, there wasn't an implementation guide. And as Gail has said, it's just been released this year. So we wanted to continue this piece of work as we had some momentum in it. So what we wanted to do is really to scope what was happening across our region. So this is the question we set ourselves. So what are health professionals' self-rated learning needs to implement optimal care pathways for Aboriginal and Torres Strait Islander people with cancer into their practice? So what did we do? So we conducted a survey, and this project, the Grampians Integrated Cancer Service also partnered with us. So we ran a survey across Gippsland and Grampians, and we used convenience and stratified sampling as we really wanted to make sure that we had people from the three disciplines of medicine, nursing and allied health to respond to the survey. And because it was a bit of a convenience sample, we were aiming for about 20 people across the 6 services, so 5 in Gippsland and 1 in Grampians. And we conducted this in the September of last year, and this is probably the most weirdest research project I've ever been involved in, because we had a cyber attack, then we had catastrophic bushfires, and we just got in before COVID-19 hit. So it's a study I'll never forget in my career. So what did we do? So we asked people to respond to a questionnaire. So we had some questions, some demographics, some practice, and some questions around the optimal care pathway and some open-ended questions. And I'll just show you the questions we had around the optimal care pathway. So this is the pathway, as Gail just showed you a snapshot of it. So what we did is we use the steps in the pathway, and we've called them categories. So we've used the steps within the pathway, and we created some sub-questions around that. And also, in this pathway, you will notice that there's this section at the front, which is an overview around Aboriginal and Torres Strait Islander perspectives. And this is what we called it, and we created some questions around that. And then we just asked people, tick which areas you would like to know more about in relation to providing care to Aboriginal and Torres Strait Islander people. Tick as many as needed. So what did we get? So we had 52 people respond across Gippsland and Grampians, so predominantly more people in Gippsland because we had more services. And as you can see in that first graph there, mostly from nursing and allied health, but it does reflect the workforce numbers that we did have. So 16 years was sort of the mean years of clinical practice, but still quite a big variety as well. And 4% of people identified as Aboriginal. So then we asked people what was their area of practice, and from this graph here you can see mostly people said they worked in the treatment area, about 50% in supportive care, and then sort of a smattering across the different practice areas. So then we had a look at some practice questions. So 79% of people said they had provided care to Aboriginal and Torres Strait Islander people. We had less than 50% saying they had done some cultural training in the last 5 years. And about 50% said they were confident in asking patients if they identified as Aboriginal or Torres Strait Islander. And only 23% were aware of the pathway at the time. So in terms of what subcategories, I guess the number of subcategories people were interested in, as you can see from this graph, so people on average identified about 23 of the items out of the 36 they were interested in. So there was quite a lot of interest across the subcategories. So I'm going to talk you through a little bit of the areas that people were interested in. So these are some busy graphs, so I will talk you through some of the key things that arise in this. So if we look at, first of all, this top section here. So these are all the categories. And as you can see, all the categories are represented there. And if you have looked down the bottom here, all the subcategories are represented as well. So if you have a look at the, I guess, the lowest category percentage, you can see here 40% of people said they were interested in keeping the GP updated. And then if you have a look at the highest subcategory, it's around cancer perspective. So 83% of people said they were interested in that. But if you look at this middle section here, you can see that a lot of these percentages are quite high. So let's have a look at what people were most interested in. So what we did with this data is we took all of these subcategories and we just ranked them from highest to lowest. And then just to divide them to have a look at what themes were emerging, we wanted to look at what were the percentages in the first quartile, so the top 25%, and also the second quartile, so the top 50%. So these orange bars indicate the subcategories in those first two quartiles. So again, I'll talk you through these. So these are, I guess, the themes that are coming out very strongly. So the Aboriginal perspectives category comes up as being a high area of interest. And then this area around, and I've grouped this together because some of the categories are some of these subcategories are similar, around diagnosis, staging and treatment. And then this area here around end of life care. And this is quite interesting because we only had about 30 to 40% of people who said they were interested in end of life care. And I guess some of the themes that come out when you look at what people have selected, most of these subcategories are things around processes and practices and trying to find out background knowledge. So if you have a look at, for example, the category around Aboriginal perspectives, so if you have a look at traditional terminology. This was, knowing when to use, what words to use, traditional medicines and gender issues. And then if you have a look at the diagnosis and treatment categories, so what influences decisions, discussing treatment options, did they understand information? And then, I guess similarly, barriers to treatment. This practices in clinics was about knowing protocols for touching and not touching, that type of thing, pain experiences and working with families. And then the issues around language, death and dying language and practices as well. So now I want to flip your attention to the bottom percentages. So these are the subcategories that emerged in the third and the fourth quartiles, and these are represented in the blue. And what clearly stands out in this section here is that this category here, care after initial treatment and recovery, which people are also calling the survivorship area, has the lowest ratings of interest for people. So treatment summaries, discussing recurrence, healthy living, social emotional well-being, mental health well-being, keeping the GP updated. And a couple of other trends that also emerge in this area, which Gail will touch on in her presentation later, is this area around supportive care. So people were interested in supportive care services, but perhaps a little bit less interested in using these tools in their practice. And then if we have a look at this next column, we saw from the previous slide that people were really interested in this end of life care, but perhaps a little bit less interested in things like advanced care planning and patient care, so referral to palliative care. And finally on this slide, I just want to draw your attention back to this first section here, where these two categories around country, family, community, health, illness and well-being were really, I guess, less of an interest for people. And we know from a lot of the research, and particularly the research that we conducted, these are really important elements to people's treatment and their recovery. So I want to share with you some open-ended comments that we got. So we asked people, how's the best way to implement the optimal care pathway? And overwhelmingly, people talked about cultural education. So in the workplace, for it to be offered flexibly, to also offer refreshers, and for really to be mandatory for interns and trainees. And also for cultural education to be delivered by and involve Aboriginal people. They also talked about wanting more information about the local community, so local Aboriginal community, and also wanted to know more about the cancer statistics for Aboriginal people. And then there were suggestions around connecting with local communities, so things like promoting events and ceremonies, and really connecting with Aboriginal services in the local towns, because these people would be the people who would help support your patients out of appointments. So this slide here, there was also some reservations as well. And people talked about this concept of putting it into practice. So when they said when there was low numbers of people, putting their learning into practice was very difficult. So this quote, my camera, in 3 years, I've had 2 Aboriginal and Torres Strait Islander patients. And then there was also this concept around understanding and respect. So people were worried about their actions might be seen as disrespectful, and as a non-Aboriginal person, could they really help? So this quote here illustrates this. So this person says, I'm very wary that I'm unlikely to be of much benefit to an ATSI oncology patient, especially given historical context of ATSI helping professions interactions. And finally, people said, stop being pretentious and treat them as people. So in summary of my presentation, I want to go back to Helen's painting, and I want to reiterate her words around the people around the outside, others' family and the support, so that everybody can play a role in supporting Aboriginal and Torres Strait Islander people. And I just want to leave you with 5 little short things that you can do that are very easy to do. So first of all, get cultural safety training, enroll or refresh, get the facts. People said they wanted the facts. Assess your own biases, because cultural safety is more than just awareness. It's about evaluating your own bias. Read the optimal care pathway, look at the implementation plan. And as Gail showed you, there's some great checklists and some guides that you can use around that. The third area is get to know your patient. So, you know, do you listen? Do you listen to what people are not saying? Do you ask the right questions? How do you include people? And take a holistic approach, because those things around wondering if you're doing the right or the wrong thing, once you know the patient, you will know what's right for that patient. So seek partnerships. So connect with your Aboriginal liaison officer. Who are they? What do they do? How can you work together? Link up with the local GP and find out who the Aboriginal Community Controlled Organisation is. What do they do? What do they offer? Can you work in partnership? And finally, promote leadership and advocacy in practice. And I've taken this quote from the implementation plan because it summarises it much more succinctly than I could. And it says, lead change in workforce cultural competency by taking part in governance committees and peer discussion, and call out bias. So thank you for the opportunity to present today. And again, I finish with some words from Helen's work, where she talks about these purple circles, and she talks about the purple circles as a brighter future. Thank you.
Thanks, Ellie. We now welcome back Professor Garvey to further discuss some of the themes arising from the survey and ways in which we can, as health professionals, provide suitable services for our Aboriginal and Torres Strait Islander patients with cancer. Back to you, Gail.
Thanks, Mark, and thanks, Ellie, for that great presentation. I think some of the slides that I'm going to be presenting work really nicely with the issues that were raised in your survey. I'm just going to share my screen now. And find the presentation. Sorry, why is it not coming up? Sorry, just bear with me, everyone. I can see lots of other things. Okay, just having a technical problem here. Let me just move it to the other side. I've got 2 screens and it's not showing. No. So, okay, let me see if this works. Apologies, Mark and everyone. Can you see that? Yes?
Yeah, it's half.
Oh, yes, yeah, so I've got to put it up on a... You can see that now?
Yes, yeah, we can.
Excellent, thank you. I'll just move everyone to the side. Okay, thanks again for the opportunity to talk about Aboriginal and Torres Strait Islander people, and particularly cancer. It's becoming increasingly clear that cancer is obviously an important health priority for Indigenous Australians. And earlier this year, there was an article, I think, in the Australian that actually reported cancer incidence cancer mortality, is the leading cause of death in Victoria, as it is in New South Wales and also Queensland. So it's a really important issue, and it's something that we need to address. Again, I'd like to thank Gail for her acknowledgement and welcome to country, and I'm very privileged being here in Queensland today to be able to present to you in Victoria and the Gippsland area. So I'm just going to give a brief overview firstly about cancer and Aboriginal Victorians, and just so that we're all on the same page and have a similar understanding. And so hopefully you can see this slide clearly, and you can see here that the dark blue dots represent non-Aboriginal Victorians and the yellow dots represent Aboriginal Victorians. And this information has come from the Cancer in Victoria Statistics and Trends 2019 report. And so if we look at these blue lines and blue dots, sorry, you can see that the, mainly between 0 and 40 here. So it means there's a lower incidence because we're talking about incidence. When we look at the Aboriginal dots, you can see that they all tend to be to the left side of non-Indigenous incidence rates for breast cancer, lung cancer, bowel cancer, prostate, and so forth. So you can see that incidence rates for Aboriginal people in Victoria are higher than what they are for non-Indigenous people for these 10 most common cancers. And you can see here that lung, breast and bowel and prostate cancer are the most common cancers for Aboriginal people. So now just looking at mortality, again we've got the same top 10 cancers here. Blue again represents non-Aboriginal Victorians, yellow Aboriginal Victorians. And so you can see from this slide here that again to the right now, cancer mortality for Aboriginal Victorians, particularly here for lung cancer, is much greater for Aboriginal people than non-Aboriginal people. Here for bowel, you can see a bigger gap. And so again, to the right-hand side is where Aboriginal and Torres Strait Islander people have higher mortality rates. So clearly in Victoria, there's higher incidence rates, higher mortality rates. So there's a lot of work that we need to do. So when we just look at Aboriginal men compared to non-Aboriginal men, you can see here that Aboriginal men are 2.9 times more likely to be diagnosed with lung cancer, 3.6 times more likely to be diagnosed with liver cancer, 2 times more likely to be diagnosed with head and neck. And when we have a look at Aboriginal women versus non-Aboriginal women, and again this is Victorian results, you can see here that Aboriginal women are 3.4 times more likely to be diagnosed with lung cancer, over 5 times more likely to be diagnosed with liver cancer, and just over 2 times more likely to be diagnosed with head and neck cancers. So again, these are some areas where we need some concerted effort, and perhaps some of those online learning modules and the other work that Emily described, particularly around head and neck, we can start to have a look at how can we do those and apply those on, develop those online learning modules with a focus on addressing Aboriginal people in Victoria's head and neck cancer rates, for example. So when we look at overall cancer mortality rates, in Victoria, cancer mortality rates were significantly higher for both Aboriginal men and women, and as a result, higher overall. And you can see here a figure which I took directly out of the document here that shows mortality rates for women here, non-Indigenous, Aboriginal women here, and similar for men. So much more significant and much more likely to die of cancer than non-Aboriginal people in Victoria. So on this slide, it's not Victorian specific, it's Australian wide. However, if we looked at the trends and what was happening in regards to cancer mortality for Aboriginal people in Victoria, it reflects what's happening in the national picture. And you can see that over time, from 1998 here, all the way up to 2016, and I apologise here that those numbers should go right to the end here, you can see Indigenous rates for cancer mortality in the orange are increasing over this time period by 21%. For non-Indigenous people, they're decreasing by 13%. So all of the strategies around closing the gap for Aboriginal and Torres Strait Islander people, clearly it's not working in cancer. The gap is widening. So that means we have to do more than what we're currently doing to close these gaps. So obviously there's a number of factors that impact on those cancer outcomes, and there's some of them listed here, and some of them I'm sure as health professionals you're quite familiar with. Later diagnosis, and that's when treatment is less likely to be effective. There's Aboriginal and Torres Strait Islander people develop cancers that have a poorer prognosis, such as lung, head and neck, pancreatic cancers. Aboriginal and Torres Strait Islander people are also more likely to have 2 or more comorbidities, with diabetes and cardiovascular disease being among the most common. Aboriginal people are also less likely to receive treatment concordant with clinical guidelines, which is a major issue and something that we should all be addressing in the healthcare system. And unmet needs, unmet supportive care needs for Aboriginal and Torres Strait Islander people are also greater in compared to the non-Indigenous people. And from the earlier presentations, obviously psycho-oncology and psychosocial issues and looking at supportive care are really important issues for Aboriginal and Torres Strait Islander people. And I was particularly concerned when Ellie put up on her slide that people were most disinterested, if I've got that right, Ellie, in the SCANAT IP, which is an Indigenous specific tool specifically addressed specifically developed, to address to identify and address the unmet supportive care needs of Aboriginal people. But hopefully I'll convince those people that it's something that they should be using in this presentation. Happy to have a discussion afterwards as well. Obviously, there's a number of cancer and cancer risk factors, and perhaps Aboriginal people have a higher incidence of some cancers and higher mortality rates because, you know, they perhaps have a higher prevalence of smoking. We know that Indigenous participations in all 3 national cancer screening programs, cervical, breast and bowel, are lower for Aboriginal and Torres Strait Islander people than non-Aboriginal people. Perhaps some of the higher liver cancer rates could be explained by risky alcohol consumption and a higher prevalence of Hep B. But we know that's not all the story. We know there's other parts to this. It's complex. There's not, a recipe for addressing cancer disparities. There's not one model that fits everyone. It's very complex, and it can also change over the cancer journey. On this slide, I've listed some factors that impact also on the cancer outcomes for Aboriginal patients. And some of these are around social cultural issues. So obviously there's a lot of mistrust of Aboriginal people in the healthcare system and in institutions based around history, based around past experiences. We've been this year, it's been a horrendous year. There's been so many really, important and impactful things that have happened, and Black Lives Matter has certainly been one of those this year. So certainly Aboriginal and Torres Strait Islander people experience racism, discrimination, which all impacts on, whether they want to access a service or not. Indigenous patients' views and understanding about cancer is also really important, that Aboriginal views of cancer, and as soon as you mention cancer, for most men, you know, I've got cancer, I'm going to die, and, you know, so then don't follow up with treatment. So communication is of the utmost importance, and how do you communicate those messages to Aboriginal patients and their families about their cancer diagnosis and hopefully subsequent treatment? Given the socio-economic sort of situation of many Indigenous people, also there's issues, financial problems and issues, transport, accommodation are particular issues. There's also healthcare system issues, and, you know, is the service appropriate to support, you know, people from more regional, remote, rural backgrounds? Are they appropriate to provide services to people with different cultural backgrounds? Are they appropriate for recognising limitations in their own communication styles and their own world views, and do they value diversity? So there's a whole range of factors that impact on the cancer outcomes. The most important thing in trying to identify how to do this at an individual level is talking to your patients, having a conversation with them. So from some research that we've been doing up here in Queensland, but also in the Northern Territory and to a lesser extent in Victoria, we've been gathering health professional perspectives about what some of the barriers are in providing care to Indigenous patients, and some of these also align with Ellie's presentation. So health professionals have said, I'm really not confident in my own communication style. I'm not sure if I'm communicating effectively to Aboriginal patients. They also have identified that they have they don't have the resources, culturally appropriate resources, to give to their patients, and that they've identified there's challenges in communicating. You know, cancer care in itself and the health system is extremely complex, as you know, as health professionals. How do you communicate that to Aboriginal and Torres Strait Islander people so that you keep them engaged in the system and not scare them away, or you know, or they misinterpret the information that you're giving them? So these factors represent some challenges, I guess, in what we have to improve Indigenous engagement in cancer care, and obviously, you know, completion of treatment and improved survival. So these are just a couple more slides around that, and again, these are from discussions with health professionals, including nurses, oncologists, Indigenous liaison officers and allied health professionals. And, you know, they said they need more Indigenous people trained in cancer. Aboriginal health workers are great, they're overwhelmed, but we need to have access to them in our cancer care teams. Patients also feel isolated when they come into the hospital setting, and there's suspicion about, well, what is radiation therapy? Like, is that like a microwave? Like, what is it? And how do you explain that to a patient so that they understand it and the importance of it in treating their cancer? And I'm sure this next point is also one that would impact on Aboriginal patients coming from the Gippsland area, where perhaps they have to travel into Peter Mac for some cancer treatment or some services. And so just remembering that people are spending time away from their home and their family. And Aboriginal and Torres Strait Islander people prioritise their family and community over themselves. And I think this is something that health professionals really struggle with, and they don't see this in many non-Indigenous patients, because an individual non-Indigenous patient is all about, yes, I need treatment, I'm staying here no matter what's happening with the family and community. And this is as reported from health professionals, whereas they see their Indigenous patients, the priorities are, oh, sorry, I've got family issues, I need to go home and I need to deal with these, and then maybe I can come back and get treatment. So how can you as a health service engage those patients so that, yes, they can attend and support the family and the community, but bring them back, and how can you get them coming back to the system? So supportive care needs, and given the brief presentation earlier, this is something that we probably don't need to spend much time on because you know the importance. It's really important in trying to prevent, reduce, alleviate symptoms of treatment, enhance communication between the patient and clinicians to assist patients and their family to manage the needs associated with their cancer diagnosis, treatment and care. So needs assessment is the patient's perspective, and so unless you ask an Aboriginal patient or a non-Aboriginal patient what their perspectives are, you're not going to address the concerns which are most important to them. They're solution focused, and they measure the gap between what their experiences and what their expectations are. So why should we assess Aboriginal and Torres Strait Islander support needs? Well, we know that they present with more complex health and wellbeing issues. Indigenous patients don't often tell us about their needs unless we ask them, and we ask the right questions. There are also cultural differences in Aboriginal perceptions of cancer. In making a decision, and maybe I need to talk to my family, it's not just about me, I can't make that decision, and we need to be able to support that, and that we know support needs vary across cultures. Also in the OCPs and also in the cancer framework, in both the OCPs tumour-specific ones and also the OCPs Aboriginal ones, they all recommend assessing for supportive care needs and using appropriate tools. And so why should we ask our Indigenous patients, and what should we ask, sorry? So we did a study some years ago to assess whether existing tools are appropriate for Indigenous people with cancer. And we actually found that existing tools are not appropriate for Indigenous people with cancer. They don't cover the issues that we see as important, and that they're not culturally appropriate. And some of the wording and some of the items in those tools are not relevant to Indigenous people, particularly around accessing the private health system or sexual needs. Our patients have told us these are things that are not important to us, but these other things around our physical and psychological, hospital needs, information and communication needs, and practical and culture needs are most important to us. And so we developed the SCANAT IP, and using that tool across 4 hospitals in Queensland, 60% reported at least one moderate to high unmet need, with psychological needs and practical needs being the most common. And so that tool has 26 questions in it with one open end. It's designed to be delivered by healthcare staff, and there's also a response guide for patients to use. Here's an example of some of the questions, and these are similar to what you might see in the supportive care needs short form 34, but physical pain, it's actually got hurt there, because that's how our Aboriginal and Torres Strait Islander people identify physical pain, through hurt, feeling tight, sleeping okay, feeling sick. So, there are some variations in the way questions are asked. So what we did is we used that tool because we developed it in a research setting. So we wanted to trial it in a usual care setting to make sure that it was feasible for patients, but also for healthcare professionals. And so we had one site in Victoria, Peter Mac actually, 2 regional sites in New South Wales, and a regional remote setting in the Northern Territory. We asked them to use the SCANAT IP over 3 to 5 months. And some of them, as Ellie had presented, they didn't see many Aboriginal patients, but some of them saw more. But when they did, they used the SCANAT IP. We asked the patients immediately after using the tool, did they think it was appropriate? Did they value it? And we asked staff at the end about the use of the tool. And so some of the results from the patients, they liked being asked about their needs, and that it was a good time. And this was mainly around just after diagnosis and during treatment. They found being asked about the needs helpful. It made them feel good that someone was showing an interest in them and that there's people out there who are trying to improve things. And I'm sure cancer care coordinators and cancer staff are all trying to do this for all their patients. And when we went to those centres, they said, we already do that, but okay, let's use the tool and see what happens. Indigenous patients said from using the tool, there was a difference in the interaction and the services that they were provided. She, the social worker, gave me some information because of some of my answers. I don't think I would have got that information otherwise. And so looking here, 58% of the patients in those services reported moderate to high unmet needs, which was reflective of our Queensland study. So we were finding the same thing across these other jurisdictions. And as a result of using the SCANAD IP, we saw additional referrals to emotional support, additional education services provided. There was more practical help. The cancer care coordinator was involved, and there were other services which weren't provided previously. When we talked to the staff, 9 out of 10 of those staff agreed or strongly agreed that they should continue to use the SCANAD IP in usual practice for their Indigenous patients. They thought it was useful, and they agreed that it was feasible to use routinely. However, what they did identify is because we're now going through and asking these questions, we spend longer with the patient initially, but then some of them say actually spending that time with them and sorting out the issues now helps things down the track, and we have less issues to resolve later. It provides patients with the opportunity to identify their needs that may not be apparent in more casual interactions. It picks up things that I thought I would never have come up until we were at a real crisis point. And I think some of the things that Ellie presented around, you know, staff from the Gippsland area not knowing what to ask Indigenous patients, well, this is what this tool is. It's a platform. It's a jumping point for you to have questions that you know are culturally appropriate to ask, then to engage them in discussions. So I guess some of the enablers around engaging Aboriginal and Torres Strait Islander people, and I guess both the OCP and the cancer framework, but also the SCANAD IP, these are strategies and that you can use to enable communication with your Aboriginal patients. They give Aboriginal patients a voice. They help you as a health professional to have these conversations with Aboriginal patients. So it's also building up trust, and it's more of a partnership rather than as a health professional and a patient. As I've said before, the healthcare system is complex and very unfamiliar and overwhelming for many Indigenous patients and for all patients. And so having someone that can be supported to chaperone those patients, understanding that Aboriginal people may also come from big families and can't be away all the time, so they might need to swap you know, who that chaperone is or who that person is that's travelling to the centre. That's an issue with the PATS travel scheme, and so there are things we need to think about. The presence of an Aboriginal health worker was reported as being crucial for assisting the patient with communication, but also the health professional in engaging with the patient. Ellie's already touched on cultural safety and cultural respect, so I won't go much into that except to say it's an important enabler for you to be trained in and have an understanding of your own cultural world views and what you can do within the service. Using culturally appropriate measures where they're available, access to culturally appropriate resources, and supporting Aboriginal cancer survivors. And so when Michelle talked about the consumer forum and the lived experiences of cancer patients, well, how can we support Aboriginal cancer survivors and those with a lived experience to be more engaged in forums and in the services that are provided, and in this case in the Gippsland sort of area. Just finishing up here in the last couple of slides, These are some just general tips, I guess, to help and assist with communication. And this is challenging, the first one, because everything is time limited and costly. But you need to take time and you need to build trust with your patient. You need to engage in more conversational type consultations so that the patient can feel more comfortable. Avoid using complex words and jargons. And I can hear you saying, yeah, we already do that. But actually, a lot of people still don't. They still use medical terms and terminology that Aboriginal people and people with low health literacy do not understand. Using diagrams, models and images to explain concepts, instructions, or what happens during treatment is really important. In the decision-making process, understanding that it might not be just up to that individual or the direct carer. There may want to be more consultation with other family members or other important people in their family network, and that will take time. We also have to understand that Aboriginal health and Aboriginal well-being is also perceived differently. Our focus is on the family and community before oneself. Extended period of silence during conversations occurs for many Aboriginal and Torres Strait Islander people. So this has to be considered the norm. And I guess, sort of just to give a word of advice, you sit there quietly until you feel really uncomfortable, and then perhaps you can ask a question. You give the Aboriginal person and their family time to consider and consolidate what the conversation is and what's been discussed. We've already talked about Aboriginal health workers and liaison officers and how they're able to assist health professionals and also patients. Here's some resources that you could actually use and access, and some links to some websites on this page. I will make these slides available to you, so you will be able to look up those. And we are developing, and I'd be really keen to talk to you, Emily, about your online module. We are working with POCOG in developing a series of online modules with a focus on Aboriginal and Torres Strait Islander people for health professionals and for researchers. And we were hoping to have this one up by NAIDOC last week, but we got held up. And so it will be available very soon. And so this is module 1, providing an overview of cancer and some of the factors impacting on health inequalities, and particularly those social cultural issues that I'm sure you'd be really interested in hearing about. So in conclusion, improving cancer outcomes for Aboriginal and Torres Strait Islander people requires everyone to play a role, and it requires a collaborative approach involving all stakeholders. And I just want to finish by saying, if you can support and change the outcomes for one Aboriginal or Torres Strait Islander people, that in itself will make a significant difference to the conversations that that person will have with their family members and with other community members, and the conversation they'll have about your service, and will encourage other people to seek cancer care and treatment at your service. And so every person counts, every number counts. And if you just see 1 or 2 people, but you can improve their cancer outcomes, you're doing a wonderful job. And that's what we've got to focus on, not the big numbers, making a difference one person at a time. So I'd just like to thank the National Health and Medical Research Council, who funds and supports my staff and the work that I do. And thank you again to GRICS, and thank you for attending the presentation this afternoon. Thank you very much.
Thanks very much, Gail. We now have a few moments to address any questions you might have. So, Marnie, have we received any questions for Gail or Ellie?
Thank you, Mark. Firstly, Gail and Ali, I'd like to thank you sincerely for your fantastic and thought-provoking presentations. Yeah, we really appreciate your time this evening. And so we did have a couple of questions come through. In the interest of time, I'm going to need to keep this quite brief.
but we will endeavour to answer any other questions that we don't get to at a later date. So I've just got one here. So did the survey respondents get asked if they were 100% sure that all Aboriginal patients were identified? I'm surprised at the MO respondent who stated that they only had 2 Aboriginal patients.
So no, this wasn't a question we asked, but I guess the question we asked around, are you confident in asking people if they identify? Only 50% of people said they were confident. So that's something that's been reported in other research as well too. So that's not unusual.
Okay, great. Thank you, Ali. And now Gina also asked Ali if you had any thoughts on why post-treatment survivorship, supportive care and communication with GP or primary care is rated lower by respondents. How can the ICS address this?
Yeah, thanks, Gina. I think the short answer to that is probably that the health system is still very siloed. So primary care, tertiary care is still in their own models. And I think there's a lot of systems issues that sometimes prevent clinicians from even being able to communicate and, you know, have that continuity of care between patients. So that is an issue that needs really some ongoing looking into.
Alrighty, thanks again. I'm just looking at the time and we're probably going to have to leave it there. We'll move on with our next presentation. So I'll just get my screen back up.
Okay, thanks, Marnie. I'll now hand over to Michelle Price, Acting GRICS Manager, to talk about the future directions for GRICS. So thanks, Michelle.
Thanks so much, Mark. I appreciate that. I try not to hold everybody up too long. I know that people are probably keen to have their dinner, but we just wanted to cover a few of the things that we've been working on and what we're currently working on at the moment. So I'd just like to introduce the new cancer plan. I'm sure that everybody is aware of this. The new cancer plan for 2020 to 2024 was released in October. It's the second plan to be released under the Improving Cancer Outcomes Act 2014, and it's continuing the momentum of the work delivered during the last 4 years in order to try and reduce risk and improve early detection and cancer care for Victorians. This plan recognises that Aboriginal Victorians have significantly higher cancer incidence, as Gail and Ellie pointed out, and they continue to experience poor outcomes when compared to other Victorians. This is reinforcing why connecting with our local Indigenous communities to improve outcomes is critical, especially for the Gippsland region. Looking at our statewide plans, so the ICS is undertaking a statewide implementation plan that will incorporate 4 agreed areas that the ICS can work together to implement, with the initiatives closely aligning to the new cancer plan. The Victorian Tumour Summits are clinician-driven forums designed to analyse statewide data for specific tumour streams and identify opportunities to improve patient experience. We recently held the Brain Tumour Summit in October, which was via Zoom, which was different. It was a very different experience than previous summits, but it was interesting in its own way. The Repeat Prostate Cancer Summit is in December, and that will also be a virtual meeting, and there will be further summits planned for 2021, and I guess we'll look at that moving forward, how they're going to look. Palliative Care and Advanced Care Planning Project is a statewide project which was initiated originally during the implementation of the head and neck and pancreatic optimal care pathways. The aim of this project is to identify any gaps in service and to ensure timely and appropriate referrals to palliative care. Additionally, we want to look at and investigate any barriers to advanced care planning discussions taking place with patients and their families, because that seems to be lagging a little bit. The Better Together program is a professional development program occurring across the state for all of the ICS staff, and it involves a capability and strength survey, 12-week free listening program, complexity and change workshop, and self-directed learning resource. The focus of the project is staff upskilling and wellbeing. The consumer engagement initiative, so this, I mentioned this previously when we were doing our work slides. This is going to be a constantly evolving project, and we'll be working on this constantly. It's something that we're very passionate about, and we really want to engage the Gippsland consumers in our work. So there's a new look for the ICS. We're going to look quite different. There's been a rebranding. Over the past 12 months, there's been significant work to rebrand the ICS to represent a cohesive group working towards improving cancer services for Victorians. Part of this strategy has included new logos for every ICS, as well as the VICS as a whole. This process included a new VICS overarching website, and each of our individual integrated cancer service websites will sit within this one master website. We'll allow 12 months. So if you go to the GRICS website link during a 12-month period, you'll be redirected to the new VICS website. There's also an ICS branding book being finalised, and that will provide a consistent approach for the ICS with new templates currently in development. And here is a sneak preview of the new VICS logo. We all think it looks pretty good. And we'll definitely keep you informed when the new logos and websites become available. I'd also like to provide you quickly with a quick synopsis of our local OCP plans, the Optimal Care Pathway plans. We are continuing with head and neck, and I won't go into that too much. The head and neck allied health education, Emily has covered that. The big bowel display, which we were very excited about, it was supposed to be at the Farm World, I think, and East Gippsland Field Days, but they were unfortunately cancelled due to COVID. Psycho-oncology I've already discussed with you, and we will continue with this as much as we can. We're working very hard on this initiative. Service mapping of existing cancer services across the region has taken place. It's been reviewed, and that again will be a moving piece. We'll constantly be updating that, and we've plans moving forward to include additional tumour streams and incorporate more health services. We have some new initiatives planned as well. We're looking at hematological cancers because it's something that we haven't covered before. So we are organising a hematological cancer conference, which again, we had that planned for later this year, but that was cancelled. We're yet to confirm a date for that conference. We think probably the focus will be on lymphoma, our work moving forward. The data's been collected, but it's not yet thoroughly reviewed. So we'll keep you posted on that. We're looking at skin cancers as well, with a focus on basal cell and squamous cell malignancies. The audit again is complete, but there's been no analysis of the data to date, so we haven't decided on project plans for that. And we will definitely be moving forward with our Aboriginal and Torres Strait Islander OCP implementation, especially now that this annual forum's finished and we can all breathe a little bit. So we'll be working with Ellie and with Gail and putting together a working group to evolve this work moving forward. Our current project plans that we're working on currently is the MDM, thanks Mum. The MDM regional project. So GRICS has funded an MDM project office for 2 years, and Chloe is undertaking a process review across the region. She's looking at existing patient pathways and service capabilities. She's also looking at improving engagement of clinicians to improve accessibility and coordination of the MDMs across all of the care pathways. GP education is planned, and we're looking at a red flag webinar event tentatively for February, with specialists providing education to GPs on areas that could expedite the patient diagnosis and treatment. Specialist sessions are also planned, and we're looking at that for next year, either via a webinar or face-to-face, and we haven't yet decided on a topic. Supportive care, obviously, Emily has covered that. And I'd like to speak a little bit about the Ophelia project. So the Ophelia process represents optimising health literacy and access to health information and services. It's a way of identifying health literacy needs and then developing and testing potential solutions. Stage 1 in Gippsland was to include the collection of current health literacy conditions and other data from our community members, and then have discussions of results presented via vignettes in workshops to generate intervention ideas. This process has obviously been delayed by COVID restrictions. However, following discussions we've had this week with Swinburne Uni, we're really excited to be able to implement this project as soon as practicable, looking at different ways that we might conduct the project. We're going to have to look at our ethics and that sort of thing, but hopefully we can get moving with that a little bit sooner than we thought. The funding initiatives will continue to provide funding to both health services and individuals in order to support innovative local projects and professional development opportunities. So thank you to everyone. The GRICS annual report, as you can see there, is now finalised, and that includes further information on our work and all of the projects that are mentioned here. If you'd like a copy emailed or sent to you electronically, please let us know and we'll get that out to you. We'd like to say a special thank you to our governance group members, stakeholders and their staff, our consumer reference group members, patient and carers, and the GRICS team for their support, assistance and contributions through the year. And just as an aside, the GRICS programme staff would also like to wish Elaine a very, very fond farewell and wish her all the very best for her future endeavours. We are really going to miss you, Elaine. Thank you.
Thank you, Michelle. On behalf of GRICS, I would like to acknowledge and thank a number of people for their assistance in the success of today's forum. Gail Menzies, thanks for providing the welcome to country. Professor Garvey and Dr. Ristevski for providing their thought-provoking presentations. Thank you very much. I'd like to thank the Department of Health and Human Services for their support and funding of GRICS. Thank you to the GRICS team for your efforts throughout the year, and in particular, preparing the forum tonight. Great work. Lastly, thank you to everyone for tuning in this evening. An evaluation survey will be circulated to your email address in coming days, and we'd really appreciate your feedback, so please don't forget to complete and return it. Thank you again. Enjoy the rest of your evening, and good night.